Good evening, everybody, and welcome to this another web-based session. This is essentially, as we said, this is from Apollo Gleneagles Hospitals, Kolkata, and courtesy this current scenario, we have taken recourse to this web-based teaching, and because our students said that there are other people who are also interested in joining and kind of interacting with us and helping us also learn, we thought that we will use another portal, and this is the portal of HCP, which is Healthcare Professionals. And this is the first time that I am trying to do this on their portal, and let's see how we go about it. So first and foremost, about the developing brain and anesthesia, there is this person who also has the developing brain. And with that, I declare my conflict of interest, which is obvious, though we like the good things in life, and despite the COVID era or not, but I don't have any conflict of interest on this particular presentation. See, the conflict with anesthesia, neonates, infants, the developing brain, the first conflict is that it is very well known that the use of a balanced anesthetic technique is beneficial in decreasing the neuroendocrine and the metabolic stress response to surgery and altering the pain processing. Where it was Anand who discussed about not only the neonate, but also during fetal surgery that you have to take care of pain. You had Fitzgerald who thought about this cutaneous hypersensitivity following peripheral tissue damage, and he was talking about including vaccination and how it altered their sense later on. And then we had people like Taddeo who said that, if there was neonatal circumcision, and if it was done without taking care of the pain, it had a significant effect later on in life and when they saw a painful procedure like vaccination. So it is essential that you take care of pain in neonates. And if you look at it from the physiological point of view, the nociceptive nervous system is mostly mature by 23 to 25 weeks post-conceptual age in humans. The nociceptive nervous system is, but the anti-nociceptive system develops much later in infancy, which means that premature and term infants are more sensitive to pain than adults. And why is this pain, especially if you don't take care of it when they're having pain, bad for the developing brain? Is because a chronic painful stimuli can provoke cell death in many areas of the brain, whether it is in the cortex, the thalamus, hypothalamus, amygdala, hippocampus. So it can cause cell death. So it's not a good thing to have. And of course, if you decide to withhold anesthesia during a painful procedure, it leads to poorer surgical outcomes, and long-term effects are seen later in childhood. And there were allusions to this in the first slide that I showed about neurodevelopmental issues, behavioral issues, and cognitive defects. So the conflict is that you should be taking care of pain, you should be taking care of consciousness when an infant or a neonate undergoes a surgical or a painful procedure. The second part of it is, this is when you throw a cat amongst the pigeons, is there has been this data which has been amassing in the literature regarding the potential adverse effects of anesthesia exposure on the developing human brain. Oppenheim, and this again is, these are elegant ones, not necessarily on human beings, but saying that it can cause cell death during development of the nervous system. The blockade of NMDA receptors can lead to apoptotic neurodegeneration in the developing brain. But what actually made people look into this kind of studies was very, very elegant studies which came out from Columbia. I think it's Columbia, Dr. Vesna, and don't ask me to pronounce the next part of her name, whether early exposure to common anesthetic agents cause widespread neurodegeneration in the developing rat brain. Is there another microphone which is on? Jayati, can you please take care of that? So
yes, sir, done.
Yeah, which brings us to the Act 3, Scene 1, the Hamletian question, or you can say the Heiderian question, to give or not to give, which is, will you give anesthetics to a surgical procedure? Will you withhold anesthetics during a surgical procedure? And will you give something which has got this potential or the neurotoxicity that comes inherently packaged with this drug? So that is this dilemma, to give or not to give. Let us look into the developing brain to understand this, okay? So immediately after birth, the brain is about 25% the adult size and is unevenly matured. The brainstem and the spinal cord are relatively well developed, whereas the limbic system and the cerebral cortex are still immature. Despite being produced before birth, the cortical neurons are poorly connected, and most of the synapses are produced after birth during what is called the exuberant phase, where there is this synaptogenesis that is happening. Okay, so this is happening after a little later on. So the newborn brain now also contains little myelin, and myelination appears to be virtually an automatic or an innate process. And for this automatic or innate process, you need sensory afferent stimuli to these neurons and the neuronal pathways, and which essentially is the neuroplasticity of the central nervous system. But this neuroplasticity of the central nervous system is a two-edged sword. And I think this is the fundamental area from where this conflict starts. You need this neuroplasticity. You need young children's brains, which should be open to learning and enriching influence, so that this automatic or innate process develops. But at the same time, it leaves them vulnerable and susceptible to a bad environmental input. So when you come to the neuronal communication of the brain, you have on one side the excitatory glutamate receptors and the inhibitory GABA receptors. And this is there in the neonate infants, and it is there as it is in the adult anatomy as well. What has been seen is that in the developing central nervous system, GABA receptors can also be excitatory, and this has possibly something to do about how anesthetics can influence the neurodevelopment of the central nervous system, which people are thinking about. You need the neurotransmitters. You need in the developing brain, these neurotransmitters play a central role in brain morphogenesis, in the formation of synapses, the proliferation, the migration of neural networks, the differentiation of the neurons, and the survival of the neurons. So you need these neurotransmitters. And during the very early stages of normal brain development, that is neurogenesis, neurons are produced much in excess. That we do not, the child or the developing child will not need this excessive neurons. And around 50 to 70% of all the neurons or the progenitor cells that are produced are eliminated. So they are lost. And this is critical for normal brain structure and function. In later stages of normal brain development, that is during synaptogenesis, and this is obviously later on, neuronal elimination is very tightly controlled. A small number of neurons are destined to die. These excess cells are eliminated by an inherent program or an inherent cell death program, which is called apoptosis. And this apoptosis is mediated by a caspase enzyme system within the cytosol, which can again be intrinsic and extrinsic. And this is a cartoon about how the programmed cell death or apoptosis happens. You have a normal cell which shrinks because of chromatin condensation. There is membrane bleeding, then the nucleus collapses, and there is continued, and then it becomes the small body formations, which is called the apoptotic body formations, and there is subsequently the lysis of the apoptotic bodies. This is programmed cell death. This is because you have excess and you want to get rid of the excess. Now let us bring in the topic of interest, that is the anesthetic agents. Are they neurotoxic? Now, general anesthetics, we all know, are highly lipid soluble. They can dissolve in every membrane, they can penetrate into organelles and interact with numerous cellular constituents. This is typically because of their lipid solubility. They have the possibility and the potential to affect gene expression and therefore protein synthesis and processing and therefore cellular function. How? It is still poorly understood. Plausible biochemical substrates for durable long-term effects in a number of tissues have been thought about. We still do not know how it happens. How did they affect? Now, this is coming to the core issue about how is it thought of that these anesthetic agents can be neurotoxics. Now, one of the things that people have thought about is this neurotoxicity is by increased apoptosis, or you are causing programmed cell death in the central nervous system. The other mechanism is it's not just apoptosis, or it could be apoptosis, plus it could be receptor mediated blocking of NMDA receptors or stimulation of the GABA receptor. So it is also could be receptor mediated. Now, apoptosis, how it is? Now, we thought that apoptosis could be intrinsic, extrinsic. This happens to the intrinsic pathway, and which is the mitochondrial dependent pathway. The anesthetic drugs causes an increase in the mitochondrial membrane permeability and therefore can release cytochrome C into the cytosol, and therefore there is a recruitment of the caspase system, and moment the caspase system is recruited, it leads to, as we thought, it is mediated by caspase, so it leads to apoptosis. And this is a cartoon again how it happens. So it can go in through receptors or go in through just the lipid permeability, goes into the mitochondria, releases cytochrome C, the caspase system is activated, and it leads to the programmed, as you can see on the top bottom left corner, the commitment to cell death. So that is about how it can. Now, okay, let us accept that it is bad. When is it bad? So what is this susceptible period? The preclinical, and this is what we talk about about preclinical, is essentially non-human studies. So preclinical studies strongly suggest a narrow window of susceptibility to this anesthesia-induced neurodegeneration. In the developing animal brain, is particularly vulnerable to neuronal cell death after anesthetic exposure in rodents up to 7 days of age, and in rhesus monkeys before 5 days of age. And the vulnerability quickly diminishes with increasing age. What about human vulnerability? Estimates for the equivalent time period in humans have ranged from the 3rd trimester of gestation to 3 years of age. So therefore, neonates, infants, and toddlers are vulnerable to anesthesia-induced neurotoxicity. This is a cartoon from the Translation of Time, which essentially this came about the development of the brain, and when you're trying to translate things that have happened with rodents and rhesus monkeys and what can happen to human beings, and why the 7 days and 5 days in this particular in primates and in rodents translates to up to 3 years. And if you are interested, this is a lovely website called Translating Time, and especially the translating time between various animals and the development of the brain, and that is how they have arrived at this 3 years time. So what are these studies on rodents and monkeys, and what do they tell us? People have found, and this from Dr. Vesna being one of the proponents on this, when anesthetic and sedative agents are administered to rodents during the synaptogenesis phase, which is again the 7-day thing, or rapid brain growth, they cause widespread neuronal apoptosis, neurodegeneration, and changes in neuron growth and cell structure. And this is what they have found, maybe looking at the brain. And from that, they have also found that the rodents who have been given anesthetics have had subsequent learning and behavioral abnormalities later on when they attained adulthood. In neonatal monkeys, ketamine or isoflurane given during this vulnerable period of brain growth causes widespread neuronal death and neural degeneration. Ketamine given to neonatal monkeys resulted in long-term behavioral abnormalities and impairments in learning and memory when the monkeys became adults. What now is the human story? I think the early 90s to and in the last couple of decades, you will find quite a few publications, and this is from the one that is a meta-analysis of that. Not a huge number, but quite a few. Not big studies, most of them small, some of them reasonably big, and most of them retrospective. And they have tried to see, and they have cohorted with it with siblings, with other normals, and try to figure out what is happening to behavioral changes, memory, cognitive functions, and learning ability on given anesthetics. And the available data so far points to a possible association between anesthetic exposure in early childhood and some learning disability. And I think a collection of this have suggested that a dose-response effect may be present. What essentially is meant by a dose-response effect is that if a particular child has received anesthetic for a longer duration or more than one, then he or she is more likely to develop a problem than the ones who have got it for a short period of time or possibly only once. But then again, you need to be always cautious with conclusions drawn for retrospective studies. But the only challenge here is that to get to a very good conclusion, planning a prospective study and for a long period of time is a huge challenge. See, the association between early anesthesia exposure and subsequent learning disability does not indicate. This is the people who are who are on the con side would say that why are you saying that somebody who received anesthesia exposure and then has learning disability, is it only due to anesthesia neurotoxicity? There could be many known and unknown confounding factors. There could be some known coexisting medical or surgical disease which leads to learning disability, which is part and parcel. Many of these studies have not accounted for that. The surgical pathology for which the person needed anesthesia, is that responsible for changes in the development of the brain? The surgical pathophysiology for which the person needed a procedure, Does that lead to a lower nutritional status in that particular infant and neonate? Does that contribute to neuronal development? That is another confounding factor that we need to understand. The other thing is, people who have received even more than one anesthetics have obviously had more hospitalization. They've stayed in hospitals for a longer period of time. They have had breaks in their normal learning process. Does that also contribute to this cognitive functions which are to develop later on in childhood, the learning ability and everything? So is anesthesia, is your sevoflurane, is your propofol, is your isoflurane, or is your ketamine responsible, or is this other things, are these other things also responsible, which makes it a very, very difficult thing to point that no, it is only anesthesia that is responsible, nothing else. Neurocognitive outcome is difficult to study in children because of growing complexity in the neurocognitive development as they age. So if you're trying to break it at 5 years, 7 years, 8 years, 10 years, 12 years, you'll find that you need to possibly check huge number of domains. So you need to, therefore, this is not this people on the con side says that the psychometric tests need to assess domains which were not applicable at younger age, and more domains need to be tested. If you're really interested, then please, I can give you Dr. Anjan Bhattacharya's number, who's a master in development pediatrics. You can talk with him and figure out how these are done. So it is not known which domain is affected most by anesthesia and its neurotoxic effect. So why is this difference between rodents, primates, and neonates? Thankfully, they are not the same, and they do not look the same, and their brains also do not behave the same way. The points to ponder is the prolonged duration of exposure to anesthetic agents. And even like one of the severe criticism of the preclinical studies has been that they have used kind of the dosaging pattern of whether it is ketamine or the inhalation pattern of isoflurane, which is similar to what has been used in humans. So without knowing what is actually the MAC values for isoflurane in rodents and monkeys, or what is the effect of the ketamine, and what is the anesthetic doses that you need for a ketamine. The second thing that has been hugely criticized in the preclinical studies has been that you have given an anesthetic wherein there has been no surgical stimulus, there has been no painful stimulus, and so you have been they have been bombarded with chemicals onto the brain without a necessity for shutting off parts of the brain. Even when you talk about the human studies, and this is what I already talked about, how much would you did you take in factor in the nutritional and the metabolic needs of the humans receiving general anesthetic? What was the monitoring standards that were used during the support? I remember this is happening in the 70s, 80s and getting published, and people then thinking about it. So is it due to the drug, or is it due to an hypoxic episode that happened, or is it due to something else, a hypotensive episode that happened, perfusion related, that is causing problems with the perfusion to the central nervous system and its added effects? And how, as again, dosing was severely questioned, and the divergent effects of anesthetic drugs given in, as I talked about, the surgical pain or stress. So the clinical relevance, as we stand today, should we be concerned? I think yes, we should be concerned, because there is some data available that yes, it can cause development, or as I can put it, some alterations in the development of the central nervous system. Is it a cause for continued research effects? Definitely. And should we therefore, based upon this, just change our sound clinical practice about giving anesthesia to people who are an infant or a neonate who's coming for a surgical procedure? I think no. Stay tuned. So what is the evidence so far? And this is, I could find, I think, these three huge, I think, today publications. This gas study, I think it's good. I think I saw Kajori had logged in from Australia. So this Murdoch's is, I think, Murdoch's Children's Research is one of the big thing in Melbourne. And they started this gas study early to 2010-11, if I remember correctly, and it got published last year in the Lancet, and they looked at 28 hospitals in Australia, New Zealand, Italy, USA, UK, Canada, and infants of less than 60 weeks post-menstrual age who were born at more than 26 weeks gestation were undergoing an inguinal herniorrhaphy without previous exposure to general anesthesia or without any risks of a neurological injury. So the patients were randomly assigned 1:1 to receive either awake regional anesthetic or a sevoflurane-based general anesthetic for their hernia surgery. The primary outcome measure that was being done was a full-scale intelligence quotient, FSIQ, or the Wechsler Preschool and Primary School of Intelligence 3rd edition, the WPPSI-3, at 5 years of age. So between February 9, 2007 to January 31st, 2013, so 6 years period, 4,023 infants were screened and 722 are finally randomly allocated, 363 awake regional anesthesia, 359 general anesthesia. The median duration of general anesthesia was 54 minutes with an interquartile range of 41 to 70. And what did they find? The FSIQ score was 99.08 in the awake regional group and 98.97 in the GA group. The difference in means was only 0.23. This provided a strong evidence of equivalence. So this results of the intention to treat analysis were similar to those of the per protocol analysis. So interpretation is slightly less than 1 hour of general anesthesia in early infancy does not alter neurodevelopmental outcomes at the age of 5 compared with awake regional anesthesia in a predominantly male study population. And the ANSCA came out with their strong recommendation that general anesthesia is therefore safe for young children. There is no significant difference in IQ scores. There is no differences in neurobehavioral and cognitive function. With the only caveat that since 84% of the study participants were male, more research was needed to confirm the findings in girls, and we also needed to find out what will happen when you have anesthesia with prolonged exposure. So that was about the gas study. Now let us talk about this PANDA study. Now PANDA is nothing but Pediatric Anesthesia and Neurodevelopmental Assessment. So this is still an ongoing study, but now it has become a kind of a group, the PANDA group. This started in 14th April. If you go to clinicaltrials.gov, you'll find it. 2009 until 2018, I think they're still recruiting, but they have met at several times in the interim, and people with similar kind of interests have come out with their findings. And one of the biggest one that has come out so far has been whether anesthesia is safe in the young, which was from the Columbia University by one of the principal inside being Sun. Sun has been one of those people who has been hugely involved with the neurotoxicity of the developing brain in children. And they looked into association between a single general anesthesia exposure before the age 36 months and neurocognitive outcomes in later childhood. This was published in JAMA in 2016. So this is among the PANDA group. The objective was to examine if a single anesthesia exposure in otherwise healthy young children was associated with impaired neurocognitive development and abnormal behavior in later childhood. So this was a sibling matched cohort study done between May 2009 and April 2015 in 4 university US-based pediatric tertiary care hospitals. So sibling pairs within 36 months in age, currently between 8 to 15 years old, and these exposed siblings were healthy at surgery and during anesthesia, and their neurocognitive and behavioral outcomes were prospectively assessed, and the retrospectively documented anesthesia exposure data were collected. A single exposure to general anesthesia during inguinal hernia surgery in the exposed sibling was one arm, and no anesthetic exposure in the unexposed sibling prior to 36 months of age was the other arm. Primary outcomes was global cognitive function. Secondary outcomes included domain-specific neurocognitive functions and behavior, a detailed neuropsychological battery-assessed IQ and domain-specific neurocognitive functions, and parents completed a validated standardized reports of behavior. What was the result? Among the 105 sibling pairs, the exposed siblings, the mean age of 17.3 months at surgery, or which needed anesthetics, 9.5% female, and the unexposed siblings had 44% were females, had IQ testing done at the mean ages between 10.6 and 10.9 years respectively. All exposed children received inhaled anesthetic agents, and anesthesia duration ranged from 20 to 240 minutes with a median duration of 80 minutes. Results: the exposed siblings IQ scores: full scale 111, performance 108, verbal 111, unexposed full scale 111, performance 107, verbal 111. So there was hardly any differences in the IQ scores between the siblings pairs, nothing that is anywhere statistically significant. So the result is there is no statistically significant difference in mean scores between the sibling pairs vis-a-vis memory, learning, motor processing speed, visuospatial function, attention, executive functions, language, or behavior. So the conclusion and relevance of this was, among healthy children with a single anesthesia exposure before the age of 36 months, compared with healthy siblings with no anesthesia exposure, there was no statistically significant difference in IQ scores in later childhood. But they have said that we need to see what happens with repeated exposure, maybe prolonged exposure, and in the vulnerable subgroups. Finally, what about the mask study? This is from Mayo Clinic, and this got published 2018 July in Anesthesiology. Unexposed, now there is singly exposed, and now they have brought in another arm, which is multiply exposed children who were born in Olmsted Country, Minnesota from 1994 to 2007, were sampled using a propensity guided approach, which means that you are doing treatment and you're trying to find out data and you're kind of looking at data which with the treatment intention for treatment was what it is supposed to be. And they underwent neuropsychological testing at ages between 8 to 12 or between 15 to 20 years, a little later on. The primary outcome they are looking at is again full-scale intelligence quotient and the WSPPI-3. The secondary outcomes included individual domains from a comprehensive neuropsychological assessment and parent reports. And what did they find? So unexposed 411, single exposure 380, multiple exposures 206 children. And if you're looking at intelligence quotient of the exposed children versus the unexposed, In the with single exposure, the intelligence quotient was 0.5 points lower, not statistically significant. Even with multiple exposures, the IQ fell down by 1.3, again, not statistically significant. That was about primary outcome and IQs. Secondary outcomes. Processing speed and fine motor abilities were decreased in children with multiple exposures. There were no significant differences in attention, memory, executive function, expressive language, visual motor abilities, or visual spatial abilities between the exposed and either unexposed and either the single or multiple exposed category. And parental reports, parents of children with multiple exposures reported more problems related to executive function, behavior, and reading, but not mathematics. Parents of children with single exposure reported more problems with executive function and reading. So this is secondary outcome results. So the conclusion from the mass study was anesthesia exposure before the age of 3 years was not associated with deficits in primary outcome of general intelligence, which is hardcore objective data. The secondary outcomes, which they say needs to be interpreted cautiously, suggest the hypothesis that multiple but not single exposures are associated with a pattern of changes in specific neuropsychological domains. We thought about learning, behavior, not necessarily maths, that is associated with behavioral and learning difficulties. So from this, whatever we heard, what is the take-home message? And the take-home message is not necessarily what I'm trying to tell you. This is a take-home message from another. I think Michael Pinsky set this up, which is the Smart Starts International Anesthesia Research Society initiative. They came out with a consensus statement in 2015. I was hoping that they've come out with something more recently. But this is what they have to say on the use of anesthetic and sedative drugs in infants and toddlers. And this is what they have to say. 6 bullet points. Brain function is very complex and cannot be fully measured with a single cognitive test. How does exposure to anesthetics affect the development of other important functions such as memory, language, motor skills, and emotional development is still not known. Sevoflurane is only one of the drugs used in general anesthesia. Do other commonly drugs produce similar results? Need to be found out. Many procedures require a combination of 2 or more anesthetics. Do the effects change when drugs are combined? Need to be known. Different medical procedures may combine with anesthetics to produce other outcomes. Are the results same for the other procedures than hernia repair? Because if you look at all this, whether the gas, the JAMA 2016 are dealing with hernia surgeries. Much brain development occurs throughout childhood. What are the exposure of anesthetics in subsequent months or children or years? We need to find out. The animal and epidemiological data suggests that the risk of anesthetics to the developing brain increases with long duration of exposure, multiple exposures, which is kind of mimicked by the mask study, the secondary outcome. Is this actually true? We need to find out. So this has been their thing. So what can be done in the future? And this is, I think, taking it a little too far, but I thought just for the heck of it, put it up, that we need to have approaches and techniques for detecting potential neuronal toxicity associated with anesthesia exposure. And how can this be done is to create a bridge between the information that we have between preclinical and this clinical anesthesia projects. The way of doing it possibly is in vivo imaging of the rodent and non-human primates by micropositive PET studies for an objective and quantitative assessment of the functional and molecular targets in a longitudinal manner, and then find out what is the cognitive and behavioral studies, put this together, and then find out what are the structure and functional issues that were not, which will possibly not be visible by other imaging studies, and which is related to anesthesia. And then if you look at molecular tracers which can label the apoptotic neurons in the brain affected anesthesia exposed rodents, ability to how they visualize and quantify the neurotoxicity. And then if you know these tracers, and then you can do live PET imaging while a human child is getting an anesthetic. Are those areas also getting affected? And can you apply the tracers and then maybe take these particular anatomical locations at which it has been found out, employ those radioactive tracers, and then possibly looking at, I think, stem cell biology or neuro, and how, don't ask me what it is, and then find out whether these tissues, if they are given these anesthetics, maybe in vitro, and then find, is there any changes that are happening to the neurons over there. So this is possibly the future. So summary, prolonged and persistent exposure to anesthetic leads to accelerated neurodegeneration. This is kind of accepted. Fetuses and neonates subject to pain and stress are also equally at risk for long-term adverse outcomes. So alleviation of pain and stress during the perinatal period is essential and humane. So the clinicians should continue to administer anesthesia to newborn infants and pregnant mothers. As such, there is yet no need to pre-warn patients or take a special consent for the neurotoxicity of anesthetics. Only two things that you can possibly do till 3 years of age is avoid unnecessary prolonged period of exposure. And if there is a surgery which the outcomes do not change whether you do it prior to 3 years of age or after 3 years of age, it possibly makes sense to delay it and do it after the age of 3. Thank you very much for a patient listening.
I'd like to thank you on behalf of HCP Forum for starting this academic endeavor with us. We hope to have you in many more future sessions, of course, and I would request all of you who have joined us tonight to please give us a feedback about whatever you find good, whatever you find needs improvement in this forum. So thank you, everyone. Thank you for joining. Thank you, Dr. Sengupta. We will close here tonight. Have a good night.
Thank you. Bye.